Hi, everyone. Thanks for being here tonight. I really appreciate it. It's a pretty fun topic for me. It's an interesting topic for all of you, I hope, because nobody really discusses organ transplantation, donation, and how we care for our recipients. So when I first began giving this course, people were saying, what does it have to do with dentistry? And I was like, no, because all of this happens with people, and people are patients or clients. So I'm going to run through the short version, since we have 50 minutes for this course. I'll be giving this course on Friday for 3.5 hours. So you can see how much was cut out of this, but it's always a pleasure to give the course. So if you ever want to know where I'm giving the full course, you certainly could reach out to me. But it's pretty cool. You're going to learn a lot tonight. So let's move on. The first thing I want to do is thank VOCO for sponsoring the course. Again, it's not a topic that a lot of people discuss. So for them to step really out of the box and think that this is a great topic and support it means a lot to me. So thank you, VOCO, very much for your support of this webinar. All right, we're going to start with something everybody loves, a quiz. I want you to pay close attention because this is a quiz about what you know at the beginning of the course. So let's go through some things here. One is organ transplant patients should not receive dental care for how long post-transplantation? 3 weeks, 3 months, 6 weeks, or 6 months? You might want to jot down what you think the answer is, and I will show you that the answer is 3 months. So it's really important that we know this because we're treating these patients. And sometimes the patients are aware that they shouldn't come in, sometimes not, often not. So I would strongly encourage you to change your health history to include the question, are you a organ transplant recipient? And if so, when? And what organ? And get the name and phone number of their transplant surgeon so you can pick up the phone and call and make sure it's okay for them to be in your chair. All right, question number 2. Which of the following conditions can be reactivated during immunosuppression? Perioabscesses, cellulitis, herpetic viruses, cytomegaloviruses, or all of the above? All of the above. Yeah, a lot can happen with these patients. Patients, give me 1 second, I have to move a bar that's on here. Okay, sorry. Patients waiting on a transplant list with chronic kidney disease and periodontitis are at a substantially higher risk of death compared to CKD patients without periodontitis. True, false, or I don't know? The answer is not going to come up. Hold on, this is not working right. Let me try to move that there. There it is, true. Love these webinars. All right, the next question. We may never just do this course. Here we go, we'll go this way. Immunosuppressed patients are at a greater risk of liver cancer, bladder cancer, squamous cell carcinoma, or pancreatic cancer. I love this question because usually it's split evenly, but the answer is squamous cell carcinoma, which is right up our alley, whether you want to recognize that or not, because we do head and neck exams on our patients. So often squamous cell carcinoma is head, neck, lip, oral. So that's where we're really going to be able to benefit by helping our transplant recipient patients. Chlorhexidine and alcohol rinses can be used to help manage oral mucositis post-transplantation. True or false? False. You do not even want it around them. So there's no benefit really to using these rinses in the majority of our patients. So many offices now have decided to just remove chlorhexidine and alcohol rinses from the office entirely. All right, in the US, 95% of citizens support organ donation. What percentage are registered donors? 45, 54, 64, or 75? 54. 95% of the US citizens support it. Only 54 have registered. So it explains a lot about what we're going to talk about with transplants and what's going on in our country. And it also goes pretty much the same around the world. So let's talk about donating the organs. This is a visual of some of the organs, but here's a great list that shows what can be transplanted. So we have solid transplantable organs listed there, and probably the one that's the most commonly talked about is kidneys. And that's because it can be from a deceased donor or a living donor. So can liver and lungs, believe it or not. But kidneys, it's the number one. But other organs that we don't often hear about are all the ones on the right under other organs. And you'll find that more and more it's becoming discussed because one deceased donor, if you look at this entire slide, has the potential to help that many people. And then if you look at the numbers that it would be, it's not just these numbers. Say that there were 20 on here. It's because some people would use multiple nerves. One person would get an eye, somebody else would get an eye, somebody would get one ear, somebody would get another. The skin can save a lot of people, muscles can. So you can see how it grows when you're a donor, how many lives you can save. So it's not like you go to the hospital and they're not going to save your life. They actually are. There's two separate teams. There's rules to follow. And then there's this thing that's called the final rule. So when the government decides that they're going to do anything with transplantation, as with other rules that we have, it's put up for a notice and you can comment on it for a specific time period. So you go online, you comment on it. They take all of the comments, all of the research, all the science, everyone gets together and they come up with what is called the final rule. And that rules how transplants are handled. So it's not that one hospital can do it their own way and another one can do it differently. It all follows the same system. There's different terminology that you should be familiar with when you're treating these patients because you might see them to get them prepped to go in to receive the transplant. You can have patients that you're seeing because they're going to get prepped to be a living donor. And always remember that when we're talking about this, there's two sides to it. There's the donors and then there's the recipients. You also will be talking to the family members. So understand they're anxious, they're scared, they need to know a lot, and it's great that we can educate them about the family member that's going to receive or the family member that's going to be a living donor. So cross-matching is a blood test that's done, and it's one of the first things that happens. And I'm going to just say about a living donor. So if you wanted to be a living donor, and we'll talk more about those specifics, but you would go for a blood test, and they're going to find out what your blood type is, and they test your blood to see if you are healthy. That's the first test. What blood type do you have, and how healthy are you? And if you pass the first one, then you would move on to deal with who a recipient could be. But even if it's that you have your mom that you're going to donate to, then you still have to have this test. So that's cross-matching. And then there's real unique things that happen. So this is a domino transplant. When I read about this, I just thought, who thought of this and how cool it was. So patient A needs lungs. Their heart is fine, but they need lungs. But the best treatment is to give patient A a combination of a heart and lung because the heart and lungs have been working together in another body. So what will happen is you have a deceased donor and patient A would get their heart and lung. And then maybe you have patient B and they don't have a donor. They will get patient A's heart. Even though A was slated to be a recipient, they became a donor at the same time. So you have two patients that were saved by one deceased donor because the healthy heart went on to someone else from patient A. So there's a lot, and that's why this is a really short snip of what it's all about. Then there's sensitized patients, and you may have heard of that, and you will treat these patients in your office before they go in to get sensitized. And that means that they might have the only chance is one donor, and that donor is almost a match, but not quite. So they can't change the donor, but they can change the recipient. So they will go in and sensitize them to accept an organ from a different blood type that might not be ideal, but prepare their body to accept, not reject the donation. So often say the recipient would go in a week and a half prior to the surgery, the transplant, just to make sure that all of it works, they're healthy and they're able, and then maybe Friday, week and a half later, they go ahead and move forward with a donation. So it's really, really interesting when you start talking about donation. So we've often heard about lists, this waiting list, and people are on a transplant list. So UNOS is the big agency, and I'm going to play this video so that you can hear about the list. I think it's important to understand what it means.
It's not a list. When we think about lists and what that means to us, I think we tend to think of standing in line or waiting on a first come, first served basis. And the waiting list isn't really a list in that sense that we think of lists. It is a pool of candidates who are waiting organ transplants, and we collect information about those candidates, information about the candidate's age, information about their blood type. But we also collect information about the donor that would be most appropriate from an age perspective, from a height and weight perspective, and in some cases from a medical social history perspective. And when donor becomes available, a list is generated within our UNET system in DonorNet, and that dynamically created list is the list that we allocate organs from. And so we're looking at information about the donors and information about the candidates, and we find those best matches and create that list dynamically. So the more donors we have, the more lists we can generate. The more organ offers we can make, the more transplants we make happen, the more lives we save.
And that's really the bottom line, is that this is all about saving lives. And when I saw this video, I thought this is a really fabulous way to explain it, because the list is ever changing every second of every day, depending on who says they can donate, who's accepted to donate, and who needs the transplant. So if someone you know needs a kidney, and there's over 100,000 people in the United States on the list right now that need a kidney, don't be shy about it. Put it on Facebook. Let everyone know. If you have a patient that needs one, ask if it's okay, where they can be contacted. Put it on your Facebook page. Let your office start a campaign. Get tested. But it's amazing what will happen. Dr. Vial is from UCLA. He's a transplant surgeon, and this was his statement, which pretty powerful. If just 0.5% of the nation's adults become living kidney donors, the kidney transplant waiting list would be wiped out 15 times over. 0.5%. So we have 2 kidneys. You can live on one. So just think, if this was something that you wanted to do, or thought about doing as a living donor, or as a deceased donor, what could happen if we really got on board with this? So let's talk about myths and facts, because trust me, I know it's not for everyone, but there's a lot of reasons people say they will never be a donor or they can't. So I wanted to dispel some of those myths. So one, I have a medical condition, so I can't be a donor. Anyone, regardless of age or medical history, can sign up to be a donor. So you can sign up when you're 75. You could sign up when you're of age, 18. You certainly can. I'm too old to be a donor. I love this one. There is no age limit. The oldest deceased donor in the U.S. was 92 years old. What matters, and it goes with both of these myths, is the health and condition of your organs when you die. So maybe they can't use your heart, but they could use your kidneys, or they could use your eye or your tendon, and you're 92. That would be amazing to help that one person live. So there's all sorts of myths, and it's fun. They see I'm a donor at the hospital, they won't try to save my life. I just heard this one today. That is not true. There's actually 2 teams. So there's a team to save your life, and then there's a team that deals with the donation. So when you're sick or injured, admitted to a hospital, the priority is to save your life. It's a sworn oath. That's what it is. The possibility for donation comes after all life-saving methods have failed. Somebody that's on life support with a brain injury and there's no hope, then the family might be talked to. They may be given a choice of saying yes or no. I strongly encourage you, if you'd like to be a donor, to let everyone know so they don't have to make that decision. So just tell people, yes, I want to be a donor if anything happens. And another big one is my family will have to pay for the donation. That is absolutely untrue. There is no cost to the donors or their families for organ or tissue donation. And I will share with you that this is for deceased and living donors. No cost at all to you. So there's a new source of transplant organs for patients with HIV. For the longest time, HIV patients could not donate or receive. It was, because of the virus, everyone had an opinion about it. And now at Johns Hopkins in 2016, they decided that they can. And the concern was about HIV positive organs. So you can donate, if you're HIV positive organs, to somebody who has the same virus strain. So the recipient with the same virus strain. Because there were a lot of people that are HIV positive, very ill, and needed a kidney. But if somebody else is HIV positive with the same strain, now they can donate. They could be on the drug regimen and be much healthier than the person that's in need. So it's come a long, long way from where it was 10 years ago with any kind of transplants. Another reason that people often say that I can't donate is because of religious beliefs, and there's actually 4 religions that have a specific statement about organ donation. The rest, I'll say that as long as it doesn't impede or hasten the death or impede the life of someone, you're saving a life. That's a very great thing to do, and the religions support it. I have people that will randomly, when I do a course, say, well, this one doesn't. I said, no, they actually do. They support it. This one doesn't. And I have some slides that show the ones that don't really support it. And they're all with caveats. So it's kind of interesting. Romani is one. Shinto is one. Amish and Jehovah's Witness. And they all have very unique statements. Some are absolute, and some are you can't donate, but you can receive. So I can't give, but I can receive a transplant. And others are in the way the transplant is done. So it's quite interesting, but overall, 96% do support it. And then we have ethical principles to deal with. So utility is one of them, and I'm just going to take you down to the bottom where they talk about who the patient is, because you have that list. You saw the video, so we have to look at who goes on that list. And they look at, this is a transplant team, what the candidates look like. So can the patient survive the surgery? Will the graft survive? What will their quality of life be after? Will it improve where they are going in? Are there any other treatments? Can they be on dialysis a little longer? As an example of something like that. And something else is their age. So it could be that somebody's in distress, they need it right away, and they're 70 something, but they need to be sensitized, where someone else could be 25 and not need to be sensitized, and they live closer to where the donor is. Those are all the types of things that they discuss. The other is justice. So how urgent is it? Has somebody been on dialysis for years and they need a transplant right now? Do they have an unusual blood type, so it's unlikely they're going to find another organ in the future, or a common one, and they will get one? How long have they been waiting? Is it the first one or their second? It's not uncommon for people to have multiple kidney transplants. How old are they, and what's the fairness? And when they look at the fairness, and I'm going to go back one slide, and they look at patient survival and quality of life, those all also take in where does the patient live from distance-wise, the surgical treatment center, can they get there? Do they have help? when they go home, and then they look at the respect for the people that are involved. So um, some people can refuse to donate. You can refuse to accept an organ. Sometimes you donate to someone you know, other times it's not directed. That's called a non-directed altruistic donation. And what's the transparency? How can you decide these things? So I have a friend that was on the transplant list, was offered some organs and was willing to accept it, but the surgeon said, we're not 100% comfortable because there's a history with this patient, a medical history with this patient, but we don't know that this is the ideal donor for you. So that donation did not happen. Now, some of the organs, this was a multivisceral transplant recipient, some of those organs may have gone to someone else, but for his situation, it was not appropriate, according to the health history that the physicians knew, to go ahead and move forward with this really heavy 5-organ transplant. So all of that comes in. Those are all the ethical principles that go in. So it's not a snap your finger and let's just do it. There's so much that's involved. So for me, it's an honor to present this month because April is National Donate Life Month. So you didn't even know it, but here you are celebrating this with me. Thank you. All right, so organ donors, they can be deceased and individual and multi-organ and living. And there's 3 types of living. There's directed, which means that I choose to donate and I'm going to donate to someone I know. There's non-directed altruistic living donor, which personally I think is a misnomer because anyone that donates, I believe, is altruistic, but that's the legal name. That means that you decide you're going to donate and you donate to a stranger. And then this final one is quite interesting. It's a voucher plan. So I choose to donate to my child. Let's just say that that's the scenario. My child will someday need a kidney. We already know that. There's an issue, but they don't need it now. So I would donate and it would go to a non-directed, a stranger. Someone on the list would get it. I get a voucher for my child. So when my child in years needs to have a kidney, they have a voucher that they're up on the list and they can receive that. So it's really interesting how much progress has been made, like I said, over the years. So directed, non-directed, and the voucher plan. So I pulled this yesterday. I'd like to do it as current as possible. And you can see for all waiting list candidates, there's 106,000, 89,000 for a kidney. And if you look down, you'll see these numbers, they're pretty powerful. So a liver, 11,000. You can be a living donor and donate part of your liver. It is a riskier surgery, higher risk of hemorrhage than donating a kidney. It's doable if you had a family member and that was the only thing. But I think, going in, you should know that. But kidney donation is not as risky as liver. So you can kind of see all of this and look at it, and it's eye-opening to me how many people are on this waiting list. All right, so what's the paired exchange? This is when I decide I'm going to donate to my mom. So I'm donor 1 and my mother would be recipient 1, but we're not compatible. But my friend wants to donate to her dad and they're not compatible. Then I could donate to the dad and my friend could donate to my mom, and that's how the paired donations work. So they're identified most of the time this particular way. Another way is called a NIAD chain. So it's a never-ending altruistic donor chain. So you have someone that doesn't have a specified person, so it's not directed. A non-directed donor donates to recipient 1 because their donor was not a match, but they matched number 2 who had a donor that didn't match, went to number 3, and so on. So in 2018, the University of Alabama had 101 on their NIAD chain. That's how long it went. That started with 1 non-directed donor, and it kept going like this visual that you see here, which is pretty darn amazing. That's a lot of lives that were impacted and saved in this one chain. So the different facts, what's your blood type, who can you receive from, and who can you donate to. So I'm A, so that means that I can receive from someone that is A or O, but I can donate to A or AB. So this is where that test comes in at the very beginning. It tests two things. What's your blood type and are you healthy? And then they start whittling down from here. So you can see if I went in and I wanted to donate, immediately they're going to start looking in the A and AB list to see then on the ethical principles, geographically who's closest, are they at the age, how sick are they, what's their survival rate, and that's how it whittles down to find the identified recipient. So if you wanted to be a living donor, these are the different things that happen and then more. So you start with donor education classes, and they're really fascinating. And we get a lot of information to read, and they encourage you to ask a lot of questions. You have a complete physical, and then women have the gynecological exam, mammograms. You do all sorts of tests, from EKGs to chest x-rays. You meet with a psychiatrist, have psychological evaluation. There's nutritional education. You meet with an ethicist because they want to be sure you understand that this is not for financial gain. That's the biggest thing. And that you understand that if you are a living donor and you're donating to someone you don't know, you may never meet them. It's not like making a new friend because you saved someone's life. You can, after 6 months, meet the recipient if you're doing non-directed, but that means you can. Both sides have to accept to meet, and that does not always happen. So what physical changes will happen? Sometimes the body is rejecting it. It sounds really scary, but the patient could just have some tweaks in the medication because remember they were on dialysis, and we'll talk just about kidneys. They were on dialysis, so they were taking care of their kidney that way. Then they have surgery. They usually feel great because their kidney's working now, but now they have all these medications in there. So it takes the body a while to get all those immunosuppressive drugs balanced and accepted. Sometimes they have to go back in the hospital. It's just to be under a close watch, but most kidney transplants are extremely successful. There just can be a few days of balancing. Usually it's just the medication. Funny when you talk about living donation because the person that usually doesn't feel so great is the donor because they were fine and they went in and had major surgery to remove a body part and they kind of feel wimpy, of course, because they had major surgery. But the beauty of it, and it's talked about all of the time, is knowing that you saved someone's life. So you feel kind of puny for a few days, but you save someone's life. And they're fighting as well. Sometimes the transplant recipients will have different things they have to deal with. So the medications might cause hair growth, acne, mood swings, weight gain, but they diminish over time. And what happens is they're just blasted with all of this medication to keep the transplant from not rejecting at the beginning. Then they start to taper down and taper down and taper down. We in dentistry have nothing to do with that. Don't ever even try and change any of their medication. In fact, you shouldn't be prescribing any medication at all. You want to be sure that you contact their physicians and ask for approval. So organ donation, it's not a tragedy. It can be a beautiful light in the midst of one because, and I've said it so many times already, but you're saving someone's life. So it's really a beautiful thing to think about. So this is an article written for patients by Cher Thomas. She's a dental hygienist, and she is a transplant recipient. So it's nice to hear from one of our colleagues talking to patients about this. So it says that dentists might have questions or concerns about, do you need antibiotics? Are you at risk for infections? Will you have a lot of bleeding? They'll want to know what medications you're taking. So if you know that someone's going to get a transplant, make sure that when you confirm their follow-up appointment, once you have the release in writing, then they know to bring in a full list of all of their medications, and not just by the name, but how often they take it and what the dosage is, how many milligrams. because you'll see it taper down, and you want to keep a record of all of that because you might notice things with them and they show you the list and you saw that last week they just changed. And if you do a head and neck exam and maybe you see a rash, and I'll show you some pictures of that, then you want to be able to say, if this is the only drug that changed, talk to your doctor about that we're noticing this now. Last week you changed from that medication. So before transplantation, we have to talk to our patients. And again, I can't recommend strongly enough that you add the questions to your health history about, are you a transplant recipient, what organ, when, doctor's names, phone numbers. You can also ask your patients if they're coming in and the living donors come in as well. So you want to make sure that everyone is screened and cared for, because not only the recipient, but the donor has to get a clearance before any transplant can take place. So what medications are they on? What are the side effects? Check with the doctor before you prescribe anything at all. And what else is going on? Do you have somebody that's diabetic? Do they have heart problems, lung issues? What's going on with your patient? So it's a pretty in-depth questionnaire that you can develop. And then, do they need antibiotics? If you Google this, you will find, I don't know, 500 different opinions about this. But the bottom line, you check with the patient's transplant surgeon and primary doctor, they recommend it. It's not an office policy. It's that one person, that patient's personal physician and surgeon, they decide, and then we get to follow along, because remember that they went through major surgery to save their life. We don't want to do anything wrong by not giving them antibiotics or by giving them antibiotics. We have to be sure that oral infection is eliminated and manage any kind of bleeding that could be occurring. Happens with end-stage liver disease. So just, again, it's communicating with the patient. And we do a really good job of that. But in this arena, we need to bump it up. I've only seen one health history that has this on it. And all it said was, are you an organ transplant recipient? It didn't ask when, and it did not ask what organ, and it did not ask for contact information. So it was good that the question was there to start, but we need to go to get the rest of the information. And then disease control, daily biofilm management, that's key. That's really key. So extractions will happen before, and then schedule considerations. Don't tell them not to go to dialysis. Schedule it on days when they're not having dialysis. And it may mean that you go in on your day off. You're not going to be doing this every week. So if you did it and your gift to this patient was that you went in on your day off so that you could do everything that they needed to be able to get the gift of life, that's your gift to them. And it's important to do small little things like that. I think it's a good thing. Donation is not for everyone, but these little things really help. Take off the orthobands if the patients will be taking cyclosporin. And anxiety, which I love, this one has nothing after it. Everyone's going to be anxious. The patient, their family, you, everyone is anxious. And when we have stress, then we have everything thrown up in the air. So our bodies build more plaque, higher risk of decay. Our diet is off. We don't sleep as well. Everything is. So yes, these patients will be extremely anxious. Know it, embrace it, support them. So what can we do? Now, this is before. Get them on a remineralization type of program. So this is Remin Pro by Voco, and it is a protective tooth cream. It has xylitol, has a hydroxyapatite, and fluoride. It's an amazing product. It comes in great flavors. I'm just going to say I'm a little biased on the melon, but it's pretty amazing. So this works. Talk to the patient about it. Listen to what the patient is telling you. So if you ask a patient, do they floss? No, why? I don't like to put my hands in my mouth. You're not going to say use Remin Pro with your finger. They don't want to put their finger in their mouth. Use a soft toothbrush. What kind of brush do you use? I use an automatic or power brush. They don't have a manual brush, so don't recommend that. But you made them whitening trays, they can use that. So put it in a tray. Personally, I have a toothbrush, I have a finger, and I have trays, and I 100% prefer the tray. I put the Reman Pro in there, and I can walk around the house, I can sit at my desk, drive my car. So it's really easy, I believe, to use the tray. Because if it's in there 15, 20 minutes once a day, that is a benefit to this patient. They're going in for a lot with their body. They don't need to come out of all of this transplant surgery and recuperation and have dental problems. Now let's talk about post-transplant. Avoid treatment for 3 months unless it's an emergency. Consult with the MD about pre-med. Don't adjust any prescriptions. If they're on cyclosporin, you're going to see hyperplasia, pretty sure. Ulcerations, yes. Mucositis, yes. Dry mouth, yes. Because the drugs they take are xerogenic drugs. Steroids, they mask infections, but there's a lot of issues that go on with all of the medications they're on, but we can't change it. And photosensitivity. So you'll notice that in your extraoral exam. Always discuss with the patients, just a little hint, you're wearing your sunscreen, right? And look them in the eye to make sure that they don't say, oh, yeah, yeah, yeah. It's imperative that they wear sunscreen all of the time, all of the time. Women will buy moisturizer and foundation that has an SPF of 30 or higher in it. You'll find that a lot. Men will be a little more difficult because maybe they weren't used to putting on moisturizer where females were. It's a generalized statement, I know, but that now you're adding a new system in to put something on their face, on their arms, on their hands, on their neck. So sunscreen is pretty important. Whoops, wrong one. Post-transplant, antimicrobial pre-rinse, check your blood pressure. What's the bleeding potential? Recommend salivary substitutes and fluoride. Be aggressive when you're treating infections. Don't say, oh, we'll check it later. I'll have you back in a month. Get on it right now. It's extremely, extremely important. And look at the behavior of the patient. What are the signs of adrenal insufficiency? They're weak, nauseated, feverish, hypertensive. And always consult with the physician, I think I said that 3 times already, about prescribing drugs, because it's common practice for us to just give a script to the patient, but don't do that, because we don't want to disrupt anything that's already been done to keep them in balance. And it shifts up and down on their medication. So they could pull one immunosuppressive drug out, knowing that they're going to put it back in. So we don't want to get involved in that at all. And then there's immunosuppressant-induced oral ulcerations that you'll see. These are lovely photos. We've seen this with a lot of our patients. These are very painful, but keep in mind that the patients don't feel great, so they might not be paying attention. It's a balance. Do I feel worse on my tongue, my lip, or my whole body? So ask them to check, talk to them before they have the transplant. Let them know that if they see any ulcers or sores to call you immediately, because we all have phones now. They can send you a photograph from their iPhone, and you can look at it and recommend something for them. Something would be Cafesol. It's a prescription. It's calcium phosphate ions, and this is a lifesaver for first week, post-op, post-surgery, oral mucositis, those ulcers. And it's just twist that top and put that in your mouth and swish it around. And now I'm going to caution you not to say swish, because when you swish, you use a lot of force, and we have very tender, raw tissue. So I tell the patient, just put it in your mouth and then close your lips together, drop your head forward, and then put one ear on one shoulder and then forward again, an ear on the other shoulder, because that rolls all of the solution around in their mouth without them swishing. That pressure of the pull of swishing is so painful, they won't follow through. But this works amazingly well, and they do it for about the first weeks. So it's just coating everything, not by scrubbing and not by swishing, but just rolling that solution around their mouth. These are other products that are available, and you may have seen a lot of these. Saliva Max and Nutricel are essentially the same thing, but Saliva Max has a pre-package that's saliva cane. So you would use the saliva cane the first week, cane anesthetic in it, when the patient's really sensitive. So it's a 7-day supply, and then you switch to the Saliva Max. So Nutricel is by, oh goodness gracious, Pharma, Arestin. They have Nutricel, Saliva Max by Forward Science. Gelclair, gelclair.com, and Rinsanol was by Sunstar. And recently it says that they're not selling it anymore, yet it's still available at Walmart and on Amazon. So it's easy for the patients to find these. If you hopefully you take a snapshot of this, but if you do a little bit of research before your patient is coming in and you know that, you can print all of this out, make recommendations for them. Maybe you can even get samples for them so they can see what it looks like, show them pictures of it. I write it down. I have a printed sheet for my patients so that they know where to go shopping for all of this. Cytomegalovirus, it's a herpes virus, but it can reactivate, especially with immunosuppression. That's these patients. So it's there always, and it looks something like this, and you can see that's really painful, really, really painful. So another one, graft versus host disease, and I'm going to go one more, head and neck exam. Check very closely. This is not uncommon. Bone marrow transplant patients, very common that they will get graft versus host disease. Solid organ transplant recipients do, not as common, but bone marrow recipients, very common. You'll see this on their hands, you see on their face, on their cheeks. You might think it's rosacea, but if you know that it's a transplant recipient, then you're going to switch your thought process, see what's going on there. Here, intraorally, you can see some images of what it all looks like. So it's quite fascinating. So you'll recommend this, triamcinolone, try and say that fast, corticosteroid, and use it for 5 to 7 days. You can use it several times a day. It works really well to decrease the pain. And then there's always our favorite magic mouthwash. So it has all of these ingredients. Here's a recipe. So you can use it every 4 to 6 hours and hold in your mouth for 1 or 2 minutes. So you see that it says hold in your mouth. We talked about the swishing. So make sure that you tell them, get it in your mouth, lean forward, and then just kind of roll your head around to coat everything. Now, what can happen with this is it can stop being as beneficial as when you started. So people will want to change up the recipe a little bit, switch it around. Here's some dry mouth products. And these are all that we've seen around many, many times. Solease, Xylomouth, Oral 7, different types of mints, clear mouth spray. Xylitol is great. Make sure that you talk to them about the dosage. They need to have 6 to 10 grams per day. So talk to the patient about what they can do. You see in the middle ice chips, remind them not to get cinnamon or lemon. Those are pretty caustic to sensitive tissue. So you might start them on something that's pretty benign, different flavor-wise, and then base bites. We've heard about all of those. Power brushes, these people have gone through so much. Don't tell them not to use it. Remind them that there's a sensitive mode. So the one on the left is a Curaden Hydrosonic. It has 7 different modes on it. So they have soft toothbrushes, sensitive brushes that you can get for power brushes, and they have sensitive modes. So bring it down to the softest, most gentle mode. Let them use the brush they're used to. If someone comes in and they have a lot of ulcerations, you can get, there's a Sunstar Super Soft, Colgate has Super Soft, Curaden has Velvet, it's a super soft brush. They can use that for a few weeks and then go back to this power brush on a gentle cycle. And then caries control, don't forget fluoride varnish. So please use fluoride varnish. And this is Voco's Profluoride Varnish, and it's one of 2 varnishes that they have. But what's interesting is that patients love the different flavors, so have them, offer them. People will accept it if it's something that they really like the flavor, but this works really well. So it's immediate fluoride release, and it relieves that hypersensitivity. So we want to control the caries. We want to make sure everything is clean. So we started with remineralization with Remin Pro. Then we went to managing the biofilm and the caries with xylitol, dry mouth products, manages the biofilm. Now we go into caries control. This slide I love because it says exactly what you tell the patients. I'm going to place this. Don't brush for 4 to 6 hours. Have a soft food diet. Better if you don't even do anything to take care of your teeth until tomorrow. And you will feel it on your teeth. Don't have hot drinks or alcohol, but you're going to feel it. Make sure you tell them that so they don't try and pick it off. Tell them just let it wear off, and then tomorrow morning go ahead and brush and floss, your normal routine. But this is, I like this for the speak, I call it, to the patient to educate them. They have a second one, Voco does, Profluoride L. It's a little bit different than the Profluoride. It is, I'm going to go here, 2 different types, sodium fluoride and calcium fluoride together. So it has the fast release, and then it has a slow long-term effect. So it's Profluoride L. It's the #1 selling fluoride in Europe, and I think in the last couple of years I learned about it. So I'll go back one slide. It's pretty incredible. It's great product. And aside, you see the second bullet, if you have patients you're doing whitening on, this does not interact or cause the whitening not to work. So you can use this, and this is for other patients besides your transplant patients. You could use Profluoride L and then go ahead and do in-office whitening or take-home whitening with it. So it's a pretty powerful fluoride varnish, Profluoride L. So different implications that we have. Bacterial, fungal, and viral infections are implicated after transplant surgery as causes for organ rejection. Yeah, that's us. Periodontal disease can have serious detrimental effects on the successful long-term outcome of patients receiving organ transplants. Everything that we have talked about care-wise of the patient and product-wise, I want you to just look at this as not only a transplant course, but also oral cancer patient course. Same issues, same side effects, use the same products. So you've just doubled your knowledge base now by treating 2 different patient pools in your practice, transplant recipients and oral cancer patients. All right, so let's talk a little bit about kidney donation. So when you donate a kidney, the surgeons prefer to take the left one because it has a longer tube. I know it sounds bad. And gives them more to work with in the recipient because they have a longer tube to place it to connect everything. If someone has damaged kidneys, you see the 2 there, and they get a transplanted one, they now have 3 kidneys. They don't remove the recipient's bad kidneys. They get a new one and they have 3. So the donor has 1 and they have 3. This woman is Jackie Gorman, and she is a writer. The title that you see here, that's an article that she wrote in the Reader's Digest. I met her. She is a non-directed altruistic living donor. That is her recipient. She was my patient. I subbed in an office and she was my first patient that day. It was very weird. And her health history said kidney donor, November 2010. And so I said, who did you donate to? Because that's the first question. And she said, a stranger. And I said, oh, I want to know all about it. Everything. Will you tell me? She said, I would love to. So she did. I saw her in July of 2012. And in December of 2012, I donated. So it was such a gift to learn from her, to meet her, but to be able to be inspired by her. So the living donor, their kidney lasts from 12 to 20 years, but a deceased donor kidney is 8 to 12. So you could see the benefit of being a living donor if that's your goal, to be a donor, because when you donate to someone, they can live 12 to 20 years with your kidney. So this year will be 10 years post-donation. I donate to a stranger here in Los Angeles area. I live in Southern California, LA area. The waiting list here on average is 9 years waiting to get a kidney. So I knew someone had been waiting a heck of a long time for I call it my bean, for my bean to live. So I feel like what a gift that that person is no longer on that waiting list and they potentially have 12 to 20 years to live. A family has a parent, a sibling, a child. So it's pretty cool. It's pretty cool. So how does it affect the donor? You need to be careful when you exercise. I can't go bungee jumping. I'm not supposed to go ride a racehorse. But, and I joked with the psychiatrist because she was really serious. And she said, yeah, you can't do things like football and boxing. And I said, do I look like I do that? I don't know. Anyway, I can't. No more rugby for me. If I do it, I have to wear protective padding. But it doesn't take the risk away if I do all of this, but it lessens it because I have one kidney now. So I'm careful. I follow the rules. I do what they say. These are some of the things that I have to do. I drink a lot of water every day. Every year I have a test. It's a blood test. They test the glomerular filtration rate just to make sure that my kidney's functioning all right. I never ate a lot of red meat, so I don't. That's the same for me. I had really low blood pressure. Now mine's about normal. So I did have an increase, but it's not bad. So those are the types of things that happen to the living donor. What does the future look like? It looks like we could have something like that inside a person now. So instead of getting a human kidney, they could have a machine implanted. It's even gotten to be this small. So we've come a long way to saving lives. Remember on that sheet, there were 89,000 people waiting for a kidney. So here's a question. The country that's the greatest amount of lives saved, it's Spain. Second to England, because they have an opt-out clause. So you don't sign up to be a donor. You are a donor if you live in Spain or England. If you don't want to be one, you have to register to not be a donor. And that's what's changed. I don't know that we'll ever see that in the United States. However, it's working in other countries, saving lives through an opt-out plan. So this is something that was sent to me, and it just really inspired me. My name is Megan. I attended a CE of yours in 2017 about transplant and donation. I left there totally inspired and knew I wanted to be a living donor one day. Well, God gave me the opportunity last month to be a living kidney donor to my friend's husband, and I did it. Imagine I received this, right? So it's pretty cool. So Jackie inspired me, and I inspired Megan. And I don't know what's better than that, I have to say. So it makes it feel like doing this course is the right thing. And I'm going to wrap it up with this video. This is Harry.
My name is Harry, and after the passing of my son, I decided to donate my kidney and make someone's life better for their children and their future. So I gave my kidney to Sheila.
My name is Sheila. I received a kidney from Harry. If it wasn't for Harry, I wouldn't be standing up here right now today. But he gave me life.
And by my mom receiving a kidney from Harry, I decided to pay it forward and donate more life. So I donated my kidney to Keenan.
And because of the generosity of Harry and Reggie, I'm able to stand here today and watch my 3 boys grow up.
Hi, my name is Jeannie, and after seeing my husband getting new life, I paid it forward and donated my kidney to Sonia.
Because of Jeannie, I'm standing here today, and because of her unselfish act, and Celia's, who is my friend who was incompatible with me, she kept the kidney chain going.
I'm Dr. Veal, and I had the honor of transplanting some of these patients. And if you look at them, you'll see their skin color doesn't match. But I can tell you their blood type and immune systems do. And from a surgeon, although the country has some tension, I can tell you that's not what I see. Because as a surgeon, a kidney is always pink. And I think we can learn a lot from these people who were strangers of different skin color and backgrounds, and they generously saved one another's lives. And we can all work together, and this transcends transplantation. And it's not just living donation, it's also deceased donation. If you're in trouble and you need an organ, you never know what the skin color, religion, ethnicity, gender, sexuality is, but we can all help one another.
So every year the Rose Parade has a float, and this was the 2022 Courage to Hope. And often you will see, and you can see people on the float and walking around. There are recipients, donors, donor families. So next year when you're watching the Rose Parade, I hope that you look at that and remember this course, and hopefully you learned something this evening. I'm going to open up, look at the Q&A, but a big thanks again to Voco for really stepping outside the box to support me presenting this information. Hopefully you've all learned something this evening, and I'm going to go ahead and look at the Q&A now and see what's there. So thank you again. So let's see. Thank you. You're welcome. Is this class for hygienists too? Yes. I am a hygienist. It's for anyone. It's for everybody. Non-dental people could certainly learn from this. Which types could A receive from? I think it was A and O. A and O. I wanted to donate for a long time, but I am young and still want to have children. Just have my first and I want more. I worry about its impact on me to do that. What are my thoughts? All right, so Jackie, she was in her late 50s when she donated. She did it after her children were grown and healthy, and she figured that they were good. And she was a grandmother. So that was her take on it. I'm single, I don't have any children, and I decided that the time was right for me at my age and where I was, that it should be something that I do. So yes, wait. I would encourage anyone that thinks they want to be a donor, register on your driver's license so that you are a registered, I can't even talk, in case there's an accident, so that your family doesn't have to make that decision. And if you, like now my family knows, so yes, I'm registered, but they know because I already donated that if something happened to me, that yes, for sure. Okay, this one. When you donate a kidney, does your GF go down 50%? Mine is not. With only one kidney now, do you need to be careful about sleeping on your side? No, not at all. So it says on your side from now on due to possible injury or pressure. That never, ever came up. Was not anything that I've ever heard about. And you have follow-up for several years. I think 2 years. You have to go every 3 months and then go back and have more tests done. So I'm free now. Thank you so much, so many of you, about liking this course. I appreciate it. And then, is partial liver transplant possible? Yes. Actually 2 years after I did my kidney, I went back to the team and said, okay, I'm ready. And they said, stop. Yeah, it's a riskier surgery than kidney donation, but yes, it is liver transplant. The liver, if I donate, it's a part of my liver is donated and it regenerates. So I missed the magic mouthwash recipe. Hopefully you got my email address and you can email me and I'm happy to send it to you. So please do that. Oh gosh, what nice things everyone is saying. I know Sherry Thomas. Yes. She let's see. Would you know if a person with anaphylactic allergies be able to donate and or receive? I believe yes, they can, but I don't know which specific allergies. So yeah, it's certainly questions to ask. And you can contact your local hospital. I donated at Cedars-Sinai. I live in the LA area. I think I said that already. UCLA has one. There's a lot of transplant centers. I have 2 friends that work with harvesting donor tissue. They thought this class was great to present dental professionals. Yes. Any of you that have a group that you want to hear this course, I'm game. So let's do it. Thank you so much. The video made me cry. I know I cried too. Put myself on the bone marrow list for my 30th birthday. I'm still waiting to donate. I've not given up hope. Don't. I have a friend that his life was saved. He's a bone marrow recipient and very blessed. I'm a registered donor on my license, so there's no question at the time of my death, which is easier for my family in the future. Yes, you can say that. However, I'm telling you honestly, if you speak to them and put it in writing, then they don't have to make a decision, because there could be one of your family that is 100% against it. So even though it's on your license, your family's still there and emotionally involved. Um, okay, what is this one? How can type O donate to anyone? Type O can only receive. I don't know. I don't make the rules. I don't know. But I want you to, Laura, you put that one in. Will you email me, please? Let's see. Is it easy for the deceased person to donate if they are a donor? Does the medical profession ask? No, I don't think I understand that one. Is magic mouthwash something patients can mix themselves? Yes, but don't. It's so much easier to have the pharmacist do it, and they do it all the time. Are you responsible for the post-test and follow-up that has to be done? No, I'm not. The company does that. So Viva Learning takes care of all of that. All right, so if you have any questions, my email's up there. Please, please, please reach out to me. I'm more than happy to answer your questions. Again, it's not like I'm trying to sell myself, but it's a message that I think dentistry needs to hear. So if you have an interest in hearing this, I think it's going to be on Viva Learning for a bit. And the live course is much longer, and you cry more. I'll let you know that. But anyway, I'm going to let you all go. I do really appreciate you taking the time and all your kind words here. Thank you so much, and have a great rest of your evening. Thank you.